what we definitely, or what physicians should know, is that it's an option. It's an option at the moment, mainly for patients with very advanced and heavily pretreated multiple myeloma, but it's increasingly being moved to earlier lines. So one should consider CAR T-cell therapy, also trials with CAR T-cell therapy in patients that have high risk or ultra high risk features or early relapses following stem cell transplantation. And I think what we should all know, or all the physicians should know, is that there are certain comorbidities that do not allow CAR T-cell therapy, at least at the moment. So cardiac disease, pulmonary disease, renal liver dysfunction, or a certain degree of renal dysfunction clearly excludes a patient from CAR T-cell therapy. And also the hematopoietic function should be kind of conserved. So it's important to select the right patient for CAR T-cell therapy according to these comorbidities. And one should also be careful when one is going to plan for leukapheresis for CAR T-cell therapy, not to expose patients to treatment that are depleting lymphocytes too much, so that we really have trouble in generating CAR T-cell therapies from the patient, for the patient. And for the long-term follow-up, I think what we really need to know, or what physicians need to know, is that there is a certain risk of CRS and neurotoxicity, which can also occur later after the transplant, so after the discharge from the CAR T-cell center. And probably what is mainly affecting the referring physician who is caring for the CAR T-cell patient later on are infectious complications. And I think that really has to be kind of well addressed in the outpatient setting.